welcome to a new episode of Home of Medicine podcast. My name is Ben Lovell and I'm a consultant in acute medicine and general medicine, and I work in London, and I'm here with my co-podcaster, Amy.
Hi Ben. Yes, thank you to everybody for tuning into this episode. And Ben, you've got a case for me.
Yes, because we're very fair and we always take it in turns. So now I've got a case for you. This is an oldie actually, and I remembered this case just last week when one of the resident doctors I was working with said, Ben, why do you always do X whenever you see this kind of patient? And I thought, why do I? Oh, I know why I always do it. It's because of this case, which I'm going to present to you now. And it's so old. I was actually an incredibly young doctor. I think I was either a foundation year 1 or 2. So we're going back into the midst of time. But I was certainly the most junior member on the team. And it's the case of an 82-year-old woman. And this 82-year-old woman was admitted from a care facility to the medical take with new onset of confusion and a mild fever. And her carers said she's not her normal self. She's more drowsy than usual. She didn't eat her breakfast, which is unusual for her. And she has a diagnosis of Alzheimer's dementia, amongst some other things, which I'll talk about in a sec. So off the bat, you have a febrile, confused, older patient from a care facility. What is going through your head?
So she has delirium. I guess she's got confusion on a background of Alzheimer's disease. So yes, it could be worsening of her dementia, although it sounds quite acute confusion. So I'd probably say this is delirium with a fever. So I'd think, okay, is there an infection somewhere going on in this patient that I need to look for? So infections that elderly people are prone to, I want to be thinking about, well, it could be anywhere, to be honest. It could be a respiratory tract infection, pneumonia. It could be a cerebral infection. Could this be meningitis, encephalitis? I'm purposely putting urinary tract infection at the bottom of my list rather than just jumping to it because you know that it's a bugbear. Well, everybody diagnoses old ladies with UTIs and they forget about all of the other infective causes. And that just annoys me a little bit because actually sometimes we miss infections of the lungs, of the skin, septic arthritis because we're so focused on urinary tract infections. However, this may not be an infection. She could be constipated. She could be a little bit hot. She could be on medications that have made her a little bit confused. She could be dehydrated. So there are lots of things that are going on in my mind really in this patient.
And I'll tell you, the referral was delirium and UTI. That was the referral to the medical take. Likely UTI, febrile and confused, older adult. So that was my receiving referral. And this is a lady who has a past medical history of hypertension, for which she took amlodipine and bendroflumethiazide, which back in those days was called, do you remember what its name was? It was bendrofluazide. They changed its name in I think the late aughts.
Did they? To bendroflumethiazide?
Yeah, it developed an M. Anyway, sidebar. I don't know, it's more difficult to spell. Hypertension on amlodipine and what was known as bendrofluazide, type 2 diabetes taking metformin, gout taking allopurinol, had an NSTEMI a few years ago, which was treated conservatively with antiplatelet therapy, and had osteoarthritis, and Alzheimer's dementia was the primary past medical history. And social history, she lived in a care facility. She needed assistance with her ADLs. She could get out of bed and walk with a Zimmer frame and someone keeping an eye on her, keeping her safe, and was not a smoker nor an ex-smoker. And I think importantly for her, and I'll tell you why I think it's important, she used to work as a dresser and a stylist in the West End in her youth, throughout her life. What I find very exciting, but why I think that's important is it's very common to admit patients to acute medicine through the take who are older adults with Alzheimer's and don't or can't or won't speak very much and give us much of a history. And we often rely on collateral histories from people who know them, which is absolutely great. But I find that it becomes very easy to get muddled up with which patient's which because they don't have any characteristics you can hang in your memory saying, oh, that's that patient, oh, that's that patient, because you can't really have an interaction with them. So one trick I learned a while ago, just to humanize these patients, is to find out what they used to do and who is this human? Who is this human who's currently lying confused in a bed in febrile and can't advocate for themselves? But finding out a little bit about who they were before this was their reality, not only in my mind just humanizes them a bit and makes them a real person rather than a case, oh, there's a delirium in bed 4, that sort of thing. But also it helps you just remember them a little bit and work out who's who, and you're less likely to get them muddled up and think, gosh, we admitted 3 patients with delirium who were all older ladies in their 80s. Which one was which again? So just finding out something just unique to them, I find is a really, really useful way forward. It just makes them more interesting. And we all got into medicine anyway because we're nosy and we like to know about people and what they do and what they did. And that was her story. So she must have had some great stories to tell if she'd been feeling a bit better and able to tell them. So that's where I was up to with that. And on examination, she was indeed febrile, 38.2 degrees, blood pressure 130/70, heart rate 94, SATs were 96 on Romer, and the respiratory rate was 18. And on examination, chest was clear, heart sounds were normal, abdomen was soft, non-tender, and she was drowsy. She was sleeping. She could be roused, but I couldn't have a conversation with her because she was not really oriented and didn't really speak very much. And the person from the care facility who'd come in with her says, oh, she's not her normal self today. She normally would answer a few questions, but she's really sleepy today. So I couldn't do a full neurological exam, of course, but I couldn't detect any focal neurology on the basics. And that's where I am with that. Blood test revealed a CRP of 97, so elevated. White cells were 14, and all other blood tests were normal. Okay, have I moved you on anywhere in your sort of thinking?
So just she's got a lot of comorbidities going on, quite a few medications. She's pyrexial, 38.2, you said. The rest of her observations are okay, although she's slightly tachycardic at 94. Saturations of 96% on room air, I'm actually happy with that. Respiration, higher side of normal at 18, but still within, I guess, normal limits. Blood pressure's 130/70. She's known hypertensive, so potentially could be higher. However, she's on amlodipine and she's on bendoflumethiazide. So has she been taking those, and has she been given, has she taken them that particular day that could have lowered the blood pressure, or is that lower than normal for her? Chest was clear, abdomen's normal, heart sounds normal, but she's drowsy. CRP and white cell count are elevated, again consistent with inflammation. So there's some inflammation somewhere. Given the pyrexia, probably you'd want to make sure she doesn't have an infection. That's really important because if she does, she'd need to be treated with antibiotics and the right antibiotics. So that's a key focus. But I really think it's important in these cases that we don't just think infection, but we think of other causes of inflammation as well, which can be possible sometimes.
I'll just throw in as well, there was an examination, there was a strong smell of urine.
Okay.
The nurse said to me, oh, I did dip the urine, doctor. It was quite cloudy and it's positive for white blood cells and nitrites.
Yeah.
What do you think of that?
Nothing.
Say more.
Because you shouldn't dip the urine of anybody who's over the age of 65. However, you said this was a long time ago, so those guidelines weren't in place. So the urine would have been dipped. You would have gone ting, nitrites, E. coli, antibiotics. However, we now know that the urine of an older bladder will shed white cells and is most likely to have some colonization potentially. So that doesn't definitely tell me that this is a urine infection. It could be, but it could be something else as well.
I completely agree. And this is relatively a new understanding, as you say. And back then, I'm talking 2006 here, 2005 maybe. All right.
No, I'm just thinking that's when I was an F1 as well.
Okay. So thinking back then, I was taught the gospel, which was if someone has a fever and a positive urine dip, they've got a UTI. And it was relatively easy. You could stop thinking then. We now know different. And there's a whole ditch the dip campaign saying that, as you said, you really don't bother dipsticking anyone over 65 because it becomes useless data, or anyone who's got a catheter. Never dip catheter bag urine because it's not useful. So over 50% of people over 65 do have asymptomatic bacteriuria, as you talk about colonization. And there's actually lots of data, including a really big systematic review from 2022 saying that treating them with antibiotics actually results in harm. in terms of antibiotic side effects, sickness, dehydration, and of course, antimicrobial resistance in that one patient, but also in the population at large. And antimicrobial resistance is one of the biggest emerging threats to humanity on the planet at the moment. We all have a little role to play, and that little role sometimes is not giving nitrofurantoin or trimethoprim to someone who's over 65 with a positive urine dip. So, and what about the smelly urine?
Again, doesn't necessarily can worry me. I mean, we all have smelly urine if you haven't been drinking very much or it's warm outside. Not well, maybe. I don't know. Does it tell you anything objectively? No, I don't know. I'm not worried about
It
smelly urine.
really doesn't. It really doesn't.
No.
If you are incontinent of urine and there's urine in on your clothes or in the bed
Mm,
with you and it's stale and it sits there for a while, it
of
smells.
course. Yeah,
And
exactly.
exactly as you said, dehydration. So
Mm,
if someone's got I see it in notes a lot, offensive smelling urine, it's like, well, hang on a minute. It's because they're profoundly dry and unfortunately they've had the urine in their clothes or in the bed with them or in their sheets with them for a while. That
exactly.
is going to smell.
Yeah.
You cannot smell nitrites. You cannot smell
No.
infection. And we need to start being a bit more strict about that because people who start treating UTIs based on their nasal passages is not the right way forward because they're not very reliable for detecting infection.
Mhm.
Now, back to my patient though. What am I going to do with her then? We've had a little rant about UTIs, but she's
Mm,
a 82-year-old who's got a bit of a hypoactive delirium on the background of dementia anyway, who's febrile with a big CRP response in her blood. She's
mm,
probably infected somewhere, causing a delirium.
mm.
Well, what do we do?
Did you say that her urine electrolytes was normal?
Yeah, so sodium was 134, so 1 little milli equivalent below. Potassium was 3.9, and the creatinine was 91, which is actually her baseline.
Okay, so that's so actually she wasn't dehydrated then, given the fact that she's on a thiazide diuretic. So that
Well, if
was
we're going to be pernickety, she might still be dehydrated, but she has not yet developed AKI.
true. That's true.
Yeah.
Her blood pressure and her heart rate is a little bit high. So I guess I'm going to do an A2E assessment, as you know, check her airway, breathing, which you've already done anyway. Make sure that she's not overloaded. You know, that she doesn't have this swollen legs. Often patients can sometimes have, particularly with amlodipine as well. So making sure I'm not going to overload her. But given the temperature, tachycardia, I'd like to give her some fluid, and often dehydration can contribute towards delirium. So I'm definitely going to give her fluid. I'd like to do a chest X-ray because we don't know where the source of infection is. And just because you don't hear anything on auscultation doesn't mean there's no infection. And actually, we could do POCUS if we thought that there was a respiratory tract infection. We all know that point of care ultrasound of the lungs is particularly effective in looking at pneumonia. So we could potentially do that. Although this was 20 years ago, Ben, I don't think POCUS was invented then, was it? I'm not sure. I
When
don't
I was a boy, we didn't have
know. Yeah,
no.
I don't know. So we would have done a chest X-ray. She's pyrexial, so I want to do blood cultures as well. I think it's really important. So basically, stick to the basics. I think it's important to do a blood gas. Again, you would have done an arterial blood gas back then, but now a venous blood gas would be okay. Let's look at the lactate and also a blood glucose as well. You know, is she delirious because she's hypoglycemic?
Mm,
She's diabetic.
mm.
So I really want to check her glucose. Basic things, really. I'm not going to do anything too fancy. I probably will send her urine off for an MSU. So midstream urine, I'm going to send off for microscopy, culture, and sensitivity, because that is really the way that you're going to identify if she actually does have a bacteria within her urine. So that's my plan for now.
Yes, another thing that just occurred to me then was you've got to remember that an ABG back in those days only had 6 data points on it, which was pH,
Did you
O2, CO2,
know?
bicarb, basic cess, and an oxygen. You didn't get a lactate. You wanted a lactate, you had to send a grey tube on ice.
Did on ice.
Yeah. So I
Yeah.
didn't have a lactate at that point. But you wanted a glucose, great thought. She's a type 2 diabetic. And when type 2 diabetes and infection mixed together, you can sometimes get some very big derangement in the blood sugars. And she was euglycemic. So that was normal. What else did you want? Sorry, you wanted
Chest X-ray.
a chest X-ray, which was clear, and there was
Yeah.
absolutely no signs on listening to her chest at all.
I would like blood cultures, which are going to take a bit of a while to
Yeah,
come
sent
back.
those. Yeah,
And I also said,
urine MSU. I sent that. Yeah.
yeah, okay. I think I'd like to look at or examine her all her skin, look at her joints, make sure there's no inflammation there,
Mm.
infection is there. If she's got any diarrhea, if there is diarrhea present, then obviously send that off for stool culture, see if there's anything there.
Yeah, I think skin's important, particularly. I mean, this is someone who was able to walk around, but people who are out of bed or out of a chair, it's super important to check they haven't what their pressure areas look like.
Absolutely.
My experience, infected pressure ulcers or indeed pressure ulcers tend to be a nursing diagnosis because their nurses, as part of their routine admission, will always check pressure areas. And they often are the ones who pick it up, take a nice picture of it, upload it to the patient's notes, electronic notes, and then let the doctors know. I don't know many doctors who are rolling patients back and forth on an ED trolley looking at pressure areas. And there's a whole variety of reasons why that should be. But nurses are usually very strict. So I always have a quick peek at what they've noticed when they've been turning the patient and just checking their pressure areas.
Yeah, absolutely. And also never forget the back of the heels as well, because actually we can look at the back of the heels in a
Oh,
patient.
they're the easy bits. Yeah.
And feet and toes, and there's often a lot of infections going on in the feet, whether it be athlete's foot or cellulitis or ingrowing toenails, again, can all cause quite big problems with infection, also mobility as well. So don't forget the feet.
So none of that. We did the test that you mentioned, and none of the immediate tests that came back revealed anything particularly interesting. So I've got to say, this patient did end up being admitted and
Yeah.
was started on intravenous antibiotics for a UTI. I
Yeah.
mean, that was the anchor, the cognitive anchor that had been dropped. So that is where we moored. And she was treated for, and I didn't really see her again until I was up on the wards again 48 hours later. Now, I don't know these days if FY1s do ward rounds on their own or if every inpatient gets a consultant review or reg review, but back in those days, and I was doing the ward round on the ward myself. And I saw her and I was a bit puzzled 40 hours later because she was getting worse. Her delirium was getting worse. She was still confused, but she was more lethargic and was quite difficult to wake, completely disoriented. And she was still intermittently febrile, so sometimes spiking up to 38 degrees and then going back to normal again. And her CRP, which I repeated, was static at 95. And this is 2 days after intravenous cefuroxime, which I believe was the antibiotic for choice there.
Yeah.
So it was 97. And then a good 2 days later on IV Kef, it was still 95. So she wasn't improving, actually. And all the other blood tests we'd done, including glucose, calcium levels, were normal. And I was a bit stuck. So I had to escalate upwards. But at that point, I was really, really not sure what was going on. I mean, even if it wasn't a UTI, 48 hours of Kef, that should sort out most things, shouldn't it? Or what do you think?
Well, okay. So the first question I'm going to ask is, have we got the infection wrong? So is this an infection, but we've got the wrong site? So cefuroxime's not going to work. So we've got no clear evidence that this is a UTI, apart from the smelly urine and the positive dipstick, which is worthless. So I'm looking for other sources of infection. You said that the lungs were clear, that the chest X-ray was normal. Do we have any blood cultures back?
No,
No.
no. And the MSU had not grown anything at 2 days.
Okay, so I'm going to be thinking about infective causes then. So the only thing we haven't touched on yet, although we did briefly at the beginning, is this a cerebral infection? So could this be meningitis? Could it be encephalitis? I've seen that, not frequently, but I have seen it in the elderly who don't improve on antibiotics and they get worse, the delirium gets worse, and they have this sort of drowsiness as well with the confusion. So would I do an LP? Would I treat for encephalitis? Would I start acyclovir? These are questions I need to ask myself. CT head. Do we need to think about doing? I mean, if we're probably going to be, if confusion's getting worse, I'm probably going to want to scan ahead to make sure that there's no bleed, space occupying lesion, no obvious infarction that we can see. Would I check a B12 and folate? Thyroid function could do. Confusion, hyperthyroidism, potentially. Okay, it's T4, TSH, T3, quite helpful. Is this an autoimmune inflammation? It tends to present a little bit earlier. There's nothing really that would suggest GCA that would cause, although GCA can have a pyrexia and confusion, not commonly. When she's not on the right antibiotics, we haven't got the diagnosis right. I'm going to scan ahead because I want to find out what's going on in her brain. I want to see if there's blood. I want to see if there's ischemia, and I'm going to start to think about 2LP or not 2LP is where
This
I'm
is the
going.
question.
Mm.
So you imagine your little Ben, FY1. I didn't have the experience to go through all of those sort of in my head. Well, what should I and what did I do you think?
I mean, I'd ask my senior doctor.
Yeah,
Yeah, I mean,
I don't think I was brave enough to order a CT head. I don't think
no.
I
You just had to put it on a piece of paper, a yellow piece of paper it was, and you'd have to walk it down to the
walk it
radiologist.
down to the ground floor. Yeah. And they
Yeah.
were quite scary, the radiologists. They were really
Oh,
scary. You had to really justify. Anyway, so I asked my consultant very nervously, they'd come and review. And the consultant came and saw the patient, had a look at the patient. And about 4 minutes into his assessment of the patient, he turned her head back and forth. And her neck was stiff as a
ah,
board. He moaned in pain as he turned it to the left and the right. He lifted the back of the head up, and her shoulders came off the bed as well because she was rigid at the neck. And he said,
wow.
"Oh, she has meningitis."
Yeah.
I'd never seen meningitis before.
Mm,
Um, and exactly as you said, he said, "Let's get a CT scan of the head
mm,
and do a lumbar puncture." And the CT scan we got pretty quickly, no mass lesion. And the reg came and did a lumbar puncture, which revealed 340 white cells, which are all
wow.
neutrophils, a low glucose of 2.1, and a protein elevated at 1.4. What bug do you think we grew from the CSF on the
Listeria
ground?
monocytogenes.
Are you in peeking at my notes?
No,
How did you know that?
because just going back, I remember being taught at medical school a really common cause of meningitis in the elderly and the young is Listeria monocytogenes, and it just came to me because I was. This is really weird, but when I was listening to you talk and talking as an F1, I was back as an F1 and F2, and I was imagining myself. I was thinking about being a little med student, and it just came to my head. So it was there in my subconscious.
Wow, your subconscious, can run the ward. It was exactly as you said, but they grew gram-positive
Mm,
rods, which are identified as listeria. I'd never seen listeria before, and as you say, it's really, really important to know because it is the third commonest
mm,
bacterial meningitis organism in older adults
mm.
after pneumococcus and then meningococcus.
Yeah.
So it's important, and the antibiotic treatment is a little bit different, which I'll talk about in a sec. But I thought that was really, really fascinating. And also, I was kind of gutted. I've never turned a patient's head before, especially not a patient who come in from a care facility with a diagnosis of a UTI. And it had not occurred to me to do. Obviously, now, and you know that it's something that you'd be looking for. And to take it back to the beginning when I said recently, a resident said to me, "Why do you always do this on this kind of patient?" And it's, "Why do you always move the head back and forth on a patient, on a delirious febrile
Mm,
patient?"
mm.
And I do to this day. I always go, "Hello, and maybe look, I'm going to feel your tummy now, and let me have a quick feel of your pulse. And I'm just going to quickly lift the blanket up and look at your legs. Thank you very much. And I'm just going to gently turn your head to the left and the right. And that's fine, isn't it good?" And it's part of it's gone absolutely into my assessment of the febrile confused older patient. And it's because of this one case. That's my previous case
Mm.
bias influencing me there.
Wow, I'm racking my brains to think what I do. And I think we'll probably talk about it on a future episode is, why do we do the things that we do? Because I'm sure I did some strange things that people go, why does she always do that? Hmm.
But that's why that lives there. So I'm always moving heads around now, which I appreciate. Maybe when the end of the bed looks a bit funny, like
Yeah.
what on earth is Dr. Lovell doing there? Is he sort of giving them a chiropractor intervention? But I'm checking for nuchal rigidity. I'm checking for meningism. Really, the funny thing about listeria, especially I've now subsequently learned in older adults, is it can present a bit funny, a bit atypically, with quite a long prodrome, which just looks like either a viral illness or just a non-specific malaise, and it's actually quite late they get the neck stiffness and the signs of meningeal irritation. So that's something I was worth knowing. And I thought that, wow, the classic pitfalls in this case was all patients have a UTI if they're a certain age and a certain sort of level of functionality. If they're febrile and confused, then all patients have a UTI if someone hands over to you that they have a UTI. Then there's all patients have a UTI if they've got a positive dipstick, and all patients have UTI if you can smell it, or if they've got offensive smelling urine, if you tend to write in the notes. And now, with a few more grey hairs on my head, I now know that positive dipstick is not diagnostic of anything. I now know that the smell of urine doesn't mean anything. I now know that there are many other forms of infection which you have to be mindful of, even though I appreciate probably the majority are UTI because they're more prone. but we can't also automatically assume it's a UTI. And also I think about listeria sometimes. I think about listeria as a funny little bug which can cause CNS infection in older adults. It's important because we treat it differently. Normally we treat bacterial meningitis with something like ceftriaxone that's going to penetrate the blood-brain barrier, but listeria actually needs amoxicillin. So if you're suspecting it, you've got to bung in a bit of amoxicillin as well as your third generation cephalosporin to cover for the CNS infection. And check the neck. That's my learning point from that whole case, was check the neck.
I love it.
And they're so easy to do.
And I've just thought of what I always do as well. And I will talk about that in the future. Maybe I've already talked about it. I don't know. But yeah, there's definitely a case that I've seen that I think we need to, brilliant. Thank you so much, Ben. That is just a lovely Home of Medicine classic episode, I think we've just done there. These are cases that we see day in, day out in acute medicine, on the take, on general medical wards, that often get diagnosed as a UTI. Like you say, there's that anchoring bias, there's that initial instinct. We forget all the other information because we know the diagnosis. It must be a UTI. Actually, sometimes it isn't, and that's really important. Thank you, Ben.
And I think the cognitive bias there we mentioned was the anchoring bias, where you anchor first, and what that leads to is something called premature closure, where you close down the analysis phase of thinking because you've decided you've got the diagnosis. It's tricky because the only way you can, well, not the only way, but the main way that most people move towards being able to think more analytically and more extensively is by experience, years of experience. You simply can't say to someone who was at my stage, a newly qualified Dr. FY1, now, don't you have anchoring bias and just don't you have premature closure? Because I don't know how to navigate that, because those are things which come from experience. And unless there's another way of teaching it that I can't think of.
I mean, this is the sort of thing I've been thinking about for years now, but I think one of the most important ways that people can learn these sort of things is by doing it and watching it as well. Being on the ward, being on ward rounds with us, listening to us talk, when we see a patient, talk about the diagnosis together, rather than it just being, you do as I say, getting people really involved in the ward round. And an awareness, I sometimes talk to doctors about anchoring and cognitive bias, and they're like, I've never heard of it. So sometimes it's just an initial awareness raising can be really important.
Yeah, or listen to a podcast about it, maybe.
Or listen to the Home of Medicine podcast, exactly. But we're saying that, and obviously people are listening to it anyway, so this episode. Thank you, Ben.
Thank you so much for letting me present my little case. It's a quickie, a short one, good one, hopefully. Thanks, everybody, for listening. We love it when people send us a message. I mean, neither of us are really tweeting or Xing anymore, whatever it's called, because anyway. But it's very easy to find us. If you want to drop us a quick message, maybe you disagree on something, that's okay. We get a couple of those, but it's always nice to know that we aren't recording in a vacuum and people are listening to us and they get something out of it. To those of you who listen to us in the car on their commute, hello. To those of you who listen to us when they're on a run, hi. Watch out for that dog. And please do continue to friends about us, so we can just extend our listenership, because it means a lot to us. Thank you very much. Thank you, Amy. And I'll see you next time.
Goodbye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.